so much.
So I know you guys are expecting Dr. Mehta, and I'm sorry if you're disappointed, but you're stuck with me. So what I'm going to be talking about this morning is biliary ultrasound. I kind of want to go over really the basics of gallbladder ultrasound. I think it's something we do every day in the clinical area. I think some of you are pretty comfortable with it. Some of you think you're pretty comfortable with it. Some of you have no idea, and when you say, oh, we'll just do a gallbladder ultrasound, they're like, you just kind of nod and smile and go into the room, put the probe on, and pray that you see a gallbladder. But I think really the only way to get good at doing any ultrasound, gallbladder included, is by actually going out and doing lots of ultrasounds. So you can hear my lecture 85,000 times over, but you're never really going to be good at it until you actually go out and actually do it. So let's go. So why do we do ultrasound? I think number one is obviously for undifferentiated upper abdominal pain. I think for me, any patient with epigastric or right upper quadrant pain is automatically going to get a bedside ultrasound because it's very quick, it's easy to do, and you can either see or not see the pathology very quickly and kind of rule that in or out right at the get-go. Obviously other things, pancreatitis, jaundice, other kind of undifferentiated fevers you can kind of think about in the kind of the critical care setting in the ICU. Okay, so anatomy is super important whenever you're doing the ultrasound. And knowing the anatomy of where you are is really important. So here's your liver, in case you weren't aware, that's in the right upper quadrant of the abdomen. And right below that is kind of the gallbladder kind of sitting there connected to the cystic duct to the common bile duct. So the problem with the gallbladder is, you know, the liver's always here. The spleen's always there, the heart's pretty much always over here. The gallbladder, it's kind of like it floats around. It can be in lots of different places. It could be right up against the skin. Like you think like this huge person, you're like, I'm never going to find the gallbladder, and then you put it on, and it's just like sitting right there underneath. Whereas you have the skinny person, and the gallbladder is like hiding behind some like the kidney. So that's why the gallbladder is so hard to find, is because it's never in the same place. You're kind of guessing as to where you're going. You know, it's like somewhere over here, and so position is really important when you're going to try to find the gallbladder. Positioning your patient is really ideal. So by actually having them up about 20-30 degrees, that'll actually drop the gallbladder down. And actually putting them onto their left side a little bit will drop that gallbladder even further into a more visible plane. So when you have that person lying flat, it might be harder to find, which almost always you guys have in the emergency department. Just if you're really having a difficult time, picking them up about 20-30 degrees at an angle, putting them a little bit on their left side, dropping that gallbladder down, it might make it easier to find. So obviously you want to use your low frequency probe. If you don't know that, that's this one and this one. This is a high frequency probe. So fancy effects. All right. So where do you put the probe? And everybody's like, oh, I put it here, I put it here. Is there a right way? No. It's the best place to put the probe is where you see the gallbladder. I'll tell you my starting point. My starting point is kind of over there. So I know it's kind of weird, but I go about the tip of the xiphoid and kind of the mid-clavicular line right in between the ribs. So like right here, that's where I actually put the probe straight through, going between the ribs. I find that is most often place where I'm most successful in finding the gallbladder. But you can go from there, you can kind of, there's the old under the rib push in and scan up approach. There's the fast approach. It's lots of different approaches. There's no wrong one. It's where you find it. I happen to find that that spot is most successful for me, and I've done a lot of these. Just saying. You can do what you want, but that works for me. All right. So you want to see the gallbladder always in two planes. You want to look at every structure you look at with ultrasound in two planes, and you want to scan through the entire structure, and you're going to measure the anterior wall and go through that. So what are we going to see? What's our anatomy? So if you're kind of right over here, you're kind of fanning through. Here's a transverse view of the abdomen. You guys know and love this type of images. So here's your liver, and there's your gallbladder hiding there. And here's your IVC, your aorta, your vertebral body, your kidney. And you might see all these structures when you do ultrasound, and sometimes it'll look just like this. And there you go. So there's your liver, your kidney, your IVC, your aorta, vertebral body, and there's your gallbladder. All right? Make sense? And you want to fan through it, up and down, up and down. Now, a lot of people are like, I can't find the gallbladder, I never find the gallbladder. So I think if you're going to take away anything from this lecture, it's knowing the association of the gallbladder with the portal triad. So if we go look at some other images. So this here is the portal triad. So this is the gallbladder and long. And this is the portal triad, and we'll go through some of the more images of the portal triad. But knowing that association is that they're physically connected. There's no way you can have a portal triad unless the gallbladder has been removed without a gallbladder fairly close by, because they're connected by the cystic duct, so they're fairly close together. And what you have to realize is that the portal triad is in the liver and the gallbladder is below that for the most part. So that means that the gallbladder is always going to be inferior to the portal triad. So if you see the portal triad, you know the gallbladder is somewhere nearby inferior. So if you see the portal triad, scan down if you're in the transverse view, or kind of aim down if you're in the longitudinal view. Right? So there's a connection there. So the gallbladder is inferior to the portal triad. You guys got that? Okay. So if you see this long view, so you can always look in two planes. So here's nice, you can see a nice long view of the gallbladder, and you can see the portal triad there superiorly. So presumably the probe is kind of in this direction. And there's a scanning there, and you can see there's actually a little line there called the median lobar fissure that actually kind of connects also the kind of, you can follow that to the gallbladder as well, if you can find it. All right, so this is another long view with the portal triad there. This is what we like to call the exclamation point. I don't make up these names, by the way, because it looks kind of like an exclamation point. Gallbladder and long, portal triad and short. All right, so wall measurements. Really, you want to look for gallbladder wall thickening. We'll go through some of the pathology later. You always want to measure the near wall, okay, the wall closer to the probe. If you measure this wall, you might get an abnormally not real thickened gallbladder wall. It's because this is a fluid-filled structure ideally, and when ultrasounds go through fluid, they go right through it. So everything past the fluid-filled structure, whether it's a bladder, is always going to be brighter. That's why if you look at the bladder, everything past the bladder is brighter. So same thing with the gallbladder. You see this is kind of a little bit brighter than over here. There's nothing different than that tissue, other than the fact that there's fluid here, so everything past it looks brighter, and that can make this wall look thicker than it actually is, the acoustic enhancement. So you always want to measure the wall that's closer to the probe. I see that a lot of people measure, they measure the far field wall, and you always want to measure the near field wall. And what's a normal wall measurement? Three is like the standard number. I like to give it like somewhere between 3 and 4 millimeters, depending on how it actually appears. But like 3 to 4 millimeters is probably the standard wall measurement. I like to zoom in. I think it's easier because you're measuring 3 millimeters, and if you actually use the zoom function, it's a lot easier than like just going does that make sense? So I like to zoom in on the gallbladder and then measure the wall. I find it easier just to make the measurement because it's you have a little more space to move the two calipers to make the measurement.
Is it correct that it has to be in the cross-sectional view? To look at the anterior wall, you have
Okay, so I do try to always do it in the cross-sectional view, and I think the reason for that is the radiologist will usually measure the wall in the short view, just because if you get it in the long view, if you go over just a little bit, you can kind of catch the curve on the side, and it can look thicker than it actually is. All right. So portal triad, this is going to be superior to the gallbladder. So if you can't find the portal triad and you find the gallbladder, so you have this big round gallbladder sitting in front of you, you know the portal triad is very close by, just a little bit superior. So if you fan your probe up very slowly and look in the general area fairly close to the gallbladder, you're probably going to find your portal triad. And what's the portal triad made of? It should be pretty easy because it's on the screen. It's the portal vein, the hepatic artery, and the common bile duct. Really, the bigger structure is really the portal vein. So there's your gallbladder, and then your cystic duct leading to the portal triad right over here. All right. So there's your cross-sectional view of the portal triad, otherwise known as the Mickey Mouse view. Right. So you have your portal vein. It's usually going to be the bigger kind of hyperechoic walled structure. And then one of these structures is the artery, and one of these structures is the CBD. It's kind of hard to tell the difference. The good thing about this is that the CBD kind of follows along with the portal vein, whereas the hepatic artery is kind of tortuous, so it kind of moves around like that. So if you do get like a long view, and I'll show you a whole bunch of examples of that. The thing that's kind of following along with the portal vein is usually the CBD. So there's your Mickey Mouse. All right, and here's kind of your long view. So here's your portal vein, and this is probably the CBD, but then you see this kind of structure here and here that's kind of this round that's almost moving in and out of the screen, and that's probably the hepatic artery. The best way to tell the difference between the hepatic artery and the CBD is with flow, because blood vessels have good flow. Amazingly enough, the common bile duct does not really have enough flow to actually pick up with color Doppler, so if you actually put the color Doppler on, there's our Mickey Mouse. So you see, here's our portal vein, here's our hepatic artery with some flow in it, and there's this structure, the other ear of Mickey Mouse with no flow in it, which means it's probably the CBD. Does that make sense? Okay. All right, so here's another example of a long view, and there's this kind of small structure following along with the portal vein, and that has no flow in it. All right. So, CBD measurements, it's really important to remember these numbers, and it's about 4 to 5 millimeters is normal, plus a millimeter for every decade over 50. So if you have an 85-year-old patient and their CBD is 8 millimeters, don't get that worried that they have CBD dilatation. Does anybody know what the normal CBD is in somebody who's post-cholecystectomy? Bueller? Stumped everybody in the room. So it's about 7 to 10 millimeters, so it can be up to a whole centimeter. So if you see the CBD in somebody, you're thinking about somebody, because they can still get choledocholitis and other biliary obstruction, even if they don't have a gallbladder anymore. So it's important to know that measurement, or not get concerned when you see a CBD that's pretty big, or the same size as the portal vein. It can be up to a centimeter, and that's normal post-cholecystectomy, because that makes sense, right? You don't have a gallbladder anymore, the bile's got to go somewhere, and the CBD is pretty much your new kind of gallbladder-ish. All right, so pathology, what are the things we're looking for on our gallbladder ultrasound? And really the big thing is stones, right? Somebody comes to write up a quadrant pain or epigastric pain, you really want to rule out cholelithiasis or cholecystitis, and stones is going to be like the first aspect of it. I think it's really hard to make the diagnosis of acalculous cholecystitis in the emergency department. I think based even on ultrasound, it's hard to make that diagnosis. I think most of these patients probably need further imaging for those. And those aren't really the patients we're looking for, the acalculous cholecystitis, because those are going to be like the sicker patients, the ICU patients. So really the patient who we're thinking about is stones. So stones is kind of obviously a big one. So what do stones look like? They're bright white, they're hyperechoic. Shadowing is a really key important part of the stone. So if the bright round dot in the gallbladder is not shadowing, you have to think twice, is this a stone or is this something else? And if you're not sure, you can have the patient turn and see if the gallbladder stone moves, because gallbladder stones are not attached to anything. They're just kind of rolling around in the gallbladder, and they'll move around as you move around with the patient. All right, so here's obviously a really big stone. You can see it's bright white, got shadowing. It's probably a good couple centimeters, looks like about 2 centimeters based on the ticks here on the side. So big stone, easy to miss. There's lots of different examples of what stones could look like. Here's a whole bunch of stones kind of gathered here at the bottom, and you can see the shadowing all the way down. Shadows should go all the way down to the bottom of the screen. And the idea is that you can't ultrasound through a gallstone, so all the waves come back, so nothing penetrates through the stone, so you're not going to see anything past the stone, like bone or anything super calcified. Here's an example of image. So you have to scan through. This is why it's really important, because if you see at the beginning, let me replay that. So here you don't see anything, but then now as you scan through it, you can see obviously there's a whole bunch of little stones kind of gathered there with shadowing. And here we are, peas lined up like in a pod, peas in a pod, but all kind of shadowing there, and you can see these gallstones all along. All right. So it's really important. It's very easy to miss the big stone in the neck because you're looking for stones in a gallbladder. But the stone in neck, otherwise known as sin, stone in neck, this is this huge gallstone, but if you're just looking at the gallbladder, you don't fan all the way through, you don't get a good long view where you see the neck, you might miss this gallstone kind of wedged into the neck. I like to think of stones in the neck, especially stones this size in the neck, as eventual cholecystitis. And I think you really have to think twice about what you're going to do with this patient just because they don't have any obvious signs of infection. When you have a stone that size wedged in the neck, you could try moving them around to see if it kind of pops out. But these patients very often are going to eventually develop cholecystitis, and they usually have a lot of pain, even if they haven't developed the infectious symptoms yet. All right, so what's the WES sign? So that's basically you have a gallstone, gallstones in the gallbladder. The gallbladder is contracted. Maybe they ate, or for whatever reason the gallbladder is contracted. So these are really hard to find because you're looking for gallbladder. You're looking for a black fluid-filled round circle, right? And if it's all contracted, then you might not see that, but it's contracted onto stones. So what you're going to see is that you're going to see the gallbladder wall, W. You're going to see the echogenic stones, E. So those are the stones, and then you're going to see the shadowing of the stones, S. Otherwise known as WES sign, W-E-S, wall, echo, shadow. So here's an example. So here's your wall there, these are your echogenic stones, and you see the shadowing. Okay, and this is really hard to find because you won't see that typical gallbladder that's full of fluid. And you might be like sitting there searching, you're like, I found the CBD. Dr. Schechter said that if I find the portal triad, all I have to do is go down and it's right there, and I don't see anything. All I see is this white thing here with shadowing. Just think you might be looking for a WES, or maybe the patient doesn't have a gallbladder. You should ask them that again, because I've gotten burned on that. Oh, I never had my gallbladder taken out. No, never, never, never. And then you like somebody else comes back 5 minutes later. Oh yeah, I had to take it out years ago. So, but this is the WES sign. It's it can be really subtle. Some other examples. Here it is, gallbladder and long. So kind of impressive. You see this long, obviously full of stones with just shadowing all the way. The hard thing about this is that sometimes bowel can look very similar to this. So it's really, really subtle. If you see the portal triad and you're kind of fanning down and you see exactly where the gallbladder should be and all you see is something like this, something to think about. All right, so tumefactive sludge. That's what sludge is called in technical terms. Why is it called tumefactive? It's not actually a tumor because it kind of has that appearance. So they call it tumefactive sludge to kind of confuse everybody. And that's basically just sand. Essentially, it's sand. It's like kind of gallstones on a micro scale, and it's just kind of schmutz, to use the Jewish term, in the gallbladder. And you'll see it kind of layering out. That's really important. That's what you'll see. Sometimes it's hard to tell the difference between sludge and artifacts, so just make sure you kind of play with your gain if you're not sure. And the sludge should really layer out. And if you have sludge, you can easily get cholecystitis because it can kind of get jammed up in there. And a lot of times you'll have sludge and gallstones, so just something to think about. So what are knot stones? So polyps and edge artifact. So what do polyps look like? Well, polyps look a lot like gallstones, bright white structure, kind of round in the gallbladder. But you see how this one is hanging, right? So what do we say that gallstones kind of follow gravity? They're just kind of rolling around. They're not attached to anything. So it shouldn't really be up against the top of the probe. So you can always have them move around to see if this round ball moves with gravity, and there will be no shadowing. And notice how this polyp doesn't have any shadowing. So here it is also in the long view, kind of hanging there. Does that make sense? So don't get confused by the polyp and the shadow. And then, so the edge artifact. So a lot of people can kind of get burned on the edge artifact in terms of when they're looking for stones, because they see kind of a little bit bright, and then you see the shadowing all the way down to the bottom of the screen. So what happens when ultrasound waves kind of hit the edge of kind of a curve, like the curve of the gallbladder, is that it basically will bounce this way. So you won't get anything back to the probe, so you'll essentially get a shadow down, because it's basically the ultrasound waves are hitting it and going off in this direction, so you're basically getting that shadow going all the way down to the bottom of the screen, which can look like the shadows of a gallstone. But it's really important to kind of tease it out, because like, you know, if this one's kind of obvious that this is the edge, but sometimes it's not as obvious. So fanning through, looking in two planes is super important to kind of differentiate out between edge artifact and gallstones, because you want to give somebody a diagnosis of cholelithiasis when it really is just edge artifact, and then you missed whatever actually is causing their symptoms. All right, so sonographic Murphys. So this is the most important finding in addition to gallstones when you're thinking about cholecystitis. Now this is not to be confused with the Murphy sign on physical exam, which I think I've spoken to a few people about, which I think is a complete waste of time. They love to teach in medical school, it has no sensitivity and no specificity, and completely useless. So I don't do it. The sonographic Murphy sign, on the other hand, is super important because it is the most sensitive finding in addition to gallstones for cholecystitis. It's not gallbladder wall thickening, it's not pericholecystic fluid. It's stones and a sonographic Murphy sign, has a positive predictive value of 92% for cholecystitis. So you have to really think twice. If the patient has a good story for it and they don't have gallbladder wall thickening, you might have to have a conversation with their radiology resident or with the surgeon saying that this patient has gallstones, they have a sonographic Murphy sign, they very well might have cholecystitis. And by the way, forgot to explain what sonographic Murphy sign is. It's not just pain when you see the gallbladder and you push on it. Because chances are, if somebody's coming in with upper abdominal pain, if you push on their upper abdomen, they're going to have pain. It's really maximal pain with visualization of the gallbladder with your probe, and that's where their pain is. So you have to actually push in lots of different places and say, okay, so you see the gallbladder, you push, and you're like, that hurts. And then I'll move over and I'll be like, no gallbladder in sight, and I'll push, and they're like, yeah, that hurts too. And I'll be like, which one hurts more? And they'll be like, well, that hurts more. Then I'm like, that's not a sonographic Murphy sign. It's, you see the gallbladder, that's where their pain is the maximal when you push on it with the ultrasound probe. Does that make sense? All right. All right. Gallbladder wall thickening. There's a lot of things that cause gallbladder wall thickening. Obviously, cholecystitis is kind of one of the bigger ones. Just something to be clear is that if the gallbladder collapses, it can look like a gallbladder wall is thickening, because if you think about it, right, you have a certain amount of wall. If you take away all the fluid in there, it's all just the gallbladder wall is going to kind of contract and might look thickening. So collapsed gallbladder can have kind of the appearance of a thickened gallbladder, just so you don't get burned on that. So if you see very little fluid in there, just think twice about whether or not the wall is actually thick, especially if it's on the borderline. Lots of other things can cause gallbladder wall thickening. Things like anything that's a fluid overload state can cause gallbladder wall thickening. So CHF, cirrhosis, anybody with ascites usually can have gallbladder wall thickening. AIDS by itself can cause gallbladder wall thickening, multiple myeloma. So a lot of different things can cause gallbladder wall thickening. Obviously, cholecystitis is number one on the list, but you have to kind of know the patient. Just because you see gallbladder wall thickening doesn't mean the patient has cholecystitis. All right, so pericholecystic fluid. This is probably the hardest thing to find on the ultrasound, and because it can sometimes be really subtle. This one's not so subtle. You can see obviously kind of fluid around here. There's a thickened gallbladder wall there. Some other examples you hear, just kind of very, so that you can see something there and you're like, that looks weird. And then obviously here you can kind of see there's some pericholecystic fluid. Not to be confused with ascites. If a patient has ascites, they're going to have pericholecystic fluid because there's fluid everywhere in the abdomen. So you can't really, if a patient has ascites, they're probably going to have gallbladder wall thickening, and they're certainly going to have fluid around the gallbladder. So not necessarily cholecystitis. Here's a really subtle example. There's some, if you kind of look carefully, there's a little bit there, and then just a little bit back here. And it's really subtle and hard to see, which is, I think pericholecystic fluid is not something we see that often, and I think if a patient has a sonographic Murphy sign, a thickened gallbladder, and the story that goes with it, I think that should be enough. Don't sweat about the pericholecystic fluid or not. So here's just an example of something really bad that's gone wrong. Essentially, obviously a really thickened gallbladder wall, there's like fluid around it, there's all this schmutz in there, but you don't see any obvious gallstones until you actually look in the neck, right? And that's where you can easily miss this big stone in the neck, right? And so that's why you got to fan through it, especially in long, because you're going to be able to see the neck a lot better in long. There's your portal triad there, so there's your exclamation point in essence. Okay, so CBD dilatation. So we're thinking about somebody has biliary obstruction, obviously choledochal lithiasis, but a lot of causes for CBD dilatation, things like masses, which is always like the worst thing that could possibly be going on, or other causes of biliary stenosis, cholestasis, different things can cause CBD dilatation depending on the pathology. So we already discussed how do we identify the CBD. Here's some examples of dilated CBD. So here we can see the portal vein there. It's got flow. Usually the structure underneath it with flow that's a lot bigger is the IVC. So this is probably IVC here. And then you see this other structure, no flow in it, but pretty big. The measurement down here is 1.1 centimeters. So that's pretty dilated. And you'll notice if the CBD is the same size as the portal vein, that's bad. It shouldn't be. So here's another example. Here's your portal vein, another structure right above the portal vein, kind of following along with it, but about the same size, so 0.8 centimeters. So if this is an 80-year-old patient, that's probably fine. But if they're 50 or 30, this is an issue. And then here you can see two structures. Remember, CBD should not be the same size as the portal vein, so there's a term for that, always terms, and that's called the double barrel shotgun sign. So it's kind of like a double barrel shotgun. So I don't know if you're looking at it head on, that you get the short view, although I don't know if anybody wants to look at a double barrel shotgun head on or the long view. So in case you weren't aware of what a double barrel shotgun is, that's what kind of this is, 2 barrels. Alright. So another, sometimes you'll see this, so here's your portal vein there, here's your CBD, and then the hepatic artery as it kind of moves in and out, is kind of sandwiched in there, so we like to call that the olive sandwich. So that you get your pieces of bread, and then you get the olive in there, olive sandwich. I don't make this stuff up, all right? Don't look at me like that. So here's an example. I have yet to be able to find a stone in the CBD, so this image is not mine. Choledocholithiasis is really hard to find, but if you see it, please let me know. So here's your portal vein, here's your CBD, and you can see your little stone in there with shadowing. I would guess that probably our machines, you really need a slightly better machine than our sonocytes, which are great. See it. Yeah, what's up?
Last month, got one with production.
Oh, awesome. What do you want?
Just saying, there's a couple of residents who have gotten it. Maybe you should.
Maybe I should do more.
You should practice.
All right. So, in conclusion, position is key. Alex sucks. You want to scan the entire gallbladder in 2 planes. Anterior wall 3 to 4 millimeters. CBD 5 millimeter plus a millimeter for every decade over 50. And if you take nothing home from this lecture other than where to find the gallbladder, and that's inferior to the portal triad and vice versa. Okay? And do lots of scans. Any questions? Wow, hands up all over. What's up? You.
So we do our bedside sono, we see evidence of cholecystitis, and then we have to get an official.
Yeah.
When is that, do we foresee that changing? Do we foresee bedside sono being a diagnosis?
This is a conversation that emergency department ultrasonographers have been having for years. And I think pretty much it's not a matter of us, it's a matter of a surgeon. Is a surgeon really going to go to the OR based on one of our scans? And if you were a surgeon and some emergency department physician said, hey, this patient got cholecystitis, you got to take out that gallbladder, and without any sort of official ultrasound in a system where with a reading other than us saying it, it's really hard to kind of make that argument. So I think, especially now, at least at county where we can get scans by a technician 5 days a week and 24 hours, 5 days a week, I think it is reasonable for the, and also there's a lot of different people doing ultrasounds in the emergency department, and how do the surgeons know whether this is somebody who actually knows what they're talking about versus somebody who doesn't know it? And then you can say, well, I can show you the images, but surgeons don't really know that much about gallbladder ultrasound. Sometimes they'll be like, okay, fine, they might admit the patient, but they still need, I think, a radiology ultrasound if they're going to cut somebody open. I think that's reasonable.
It's also a huge Josh about billing, right? So it's all about billing. Because if you're in that building, we're doing it on 2 sides of the street. We're 2 public hospitals, and we're not billing for it, but those radiologists are billing for it. So they're billing for the professional component and the technical component, which is just low-lying fruit for them. So it's a lot about. First of all, it's a lot about billing. The way I look at it is like an EKG, right? So you read the EKG and you interpret the EKG, and some cardiologist 3 days later reads the EKG and bills for it. So it depends upon your particular institution. If your people want to bill for it in the emergency department, and a lot of hospitals do the ultrasounds, then that's a battle between emergency medicine and radiology, which, because we're public hospitals, we just know that update.
We do bill for some things, but if the radiologist does it, so